Hello, all, and welcome to the Platinum Performance Podcast. I'm Jessie Bengoa, and today is a big one. We've obviously covered today's topic often throughout the years in Platinum Magazine, educating alongside veterinarians at various symposiums and events, and right here on the podcast. This subject is weighty. It's a significant fear for horse owners, and it's one that's wrapped in so much progress in terms of advancements and how to prevent it, treat it, operate it, recover it. But the fear remains because it's unfortunately a not so uncommon occurrence for our horses. We're talking colic today, ladies and gentlemen, and with me to do that are two of the foremost experts in the study of equine colic, as well as its treatment and prevention in a clinical setting. So here with me, and first up, is our longtime and very dear friend, Dr. Diana Hassel of Colorado State University in Fort Collins. Dr. Hassel she's brilliant and lovely and a massively high-achieving athlete in her own right. She's an Ironman triathlete who has competed around the world. And I, like so many that know her, have always been convinced that she holds this superpower when treating these equine athletes because she understands them. She is them. She gets it. She's a high-powered athlete herself. But she also holds a PhD and double board certifications in equine surgery and also veterinary emergency and critical care. And she's spent her career on the forefront, and her work on the gut microbiome and in colic has really helped push veterinary medicine forward. So Dr. Hassel, welcome, my friend. It's so good to have you here.
Thank you so much, Jessie. And that was a very kind description of my background. I appreciate that.
Well, those who know you would completely agree. And next up is another powerhouse equine veterinarian coming to us from North Carolina State University, and that is the incredible Dr. Liara Gonzalez. And Dr. Gonzalez, too, holds a PhD and is board certified in surgery, specializing in intestinal disease. So she is our girl today. Happy to have her here. And she takes her research that is truly on the cutting edge and so beautifully translates it, into clinical interventions, bringing it to life, and also expanding the knowledge of how veterinarians can better treat and heal their patients experiencing acute intestinal disease. Dr. Gonzalez, thank you for this incredible body of work of yours and for joining us here today to give us your insights on colic. Welcome, madam.
Thank you so much. I'm so excited for this opportunity and to join Dr. Hassel because she is spectacular. And so every opportunity I have to work with her, I'm just greatly appreciative.
Couldn't agree more. And let's head right into it, shall we? This is a big topic. We could be here all day, but we're going to try and condense it down for you, ladies and gentlemen. And Dr. Gonzalez, if you would, how about you set the stage for us a bit? What is equine colic? As a very general synopsis, and why does this continue to be something that's so feared? Why is colic a problem in horses, and what in general makes horses so vulnerable to colic?
Great, thank you. Yeah, so colic is a very general term, actually, and it relates to any discomfort associated with the abdomen. So my specialty and Dr. Hassel as well has related to the intestine, and it is the most common probably cause of colic, but it's not the only cause of colic. So just keeping in mind that colic generally is abdominal discomfort. And the problem is we actually don't totally understand what causes colic. And so if we understood what caused it, then we could give specific recommendations in how to prevent it. We have some ideas of ways that could prevent it, but the very best, most cared for horse still has the potential to colic. And there's lots and lots of causes of colic that are just absolutely not preventable. And those are the ones that we tend to see in our hospitals and that might need surgery actually are the ones that doesn't matter how great an owner you are. Unfortunately, it just can happen.
Yes, it certainly can. And, Dr. Hassel, following up on that, the study of equine colic it's been quite the ride. I mean, I remember writing about colic when our founder at Platinum, the revered Dr. Doug Herthel, was still alive and practicing. And I think it was in the second issue of Platinum Magazine years ago now. And we talked a lot about how far we've come. I mean, Dr. Herthel was part of the very first ever successful colic surgery at UC Davis back around, I think it was 1969, 1970, 1971, in that neighborhood. And that was alongside other legends in the field like Dr. Nat White, Dr. Jimmy Moore, among others. And it's mind-blowing to think that not that long ago, colic surgery had a 0% chance of surviving. I mean, no survival rate. And now we're talking above 90. So talk to me about where we've been, how the understanding of colic has progressed, the treatment, the prevention, how it has all moved forward and where we are now.
Yes, fortunately, there's a lot of really great people out there that have done some great research throughout the years, and a lot of great clinicians, really, that have just paved the way and made huge strides in toward improving prognoses for these horses that develop signs of colic, as well as improving diagnostics, prognosticating, and also to some degree prevention. We still haven't mastered that one, however. And it's just, and it also incorporates other disciplines. So anesthesiologists, for example, their advances in improving the status of these really critically ill patients undergoing surgery, that's another important stride forward. And then, of course, all of our critical care work that has improved our increased understanding of fluid therapy and other support mechanisms to help improve the outcomes of all these horses. All those things kind of combined together, I think, have contributed to improved prognoses. And there's still some conditions that we just really struggle with, no matter what, no matter how much, you know, if their finances are unlimited and we have the best horses in the world. In fact, those ones tend to give us the most trouble. But the there's still some conditions where we really struggle. For example, like large colon volvulus that's very severe and very tight. Sometimes there's nothing we can do to save those animals because of the location of where the strangulation occurs and having viable bowel that we could remove properly. And so, yeah, so just over the years, we've, I think, just slowly crept up on improving the knowledge and outcomes of these patients. And one example is our Havermeyer conference coming up. So where we put all the great minds and researchers together and just talk about what's next in colic research and what is the most cutting edge and most recent stuff, and hopefully establish some collaborations and share ideas. And so these are opportunities to make strides forward for sure. And we appreciate Platinum sponsoring the event coming up next January too.
Well, we really believe in the work that's happening, and I love how you said what you said, because I think it's a misconception in a lot of ways in medicine where a lot of people think that it's one big bang discovery that just revolutionizes everything. And in fact, it's all of these smaller incremental improvements, right, that come together to achieve big things when added up together. So yes, I mean, there's been tremendous progress made. And I think the Havemeyer meeting that's upcoming in January is a big deal. It gets you and Dr. Gonzalez and your colleagues in a room, and it's amazing what happens when bright minds come together. So Dr. Gonzalez, I want to turn to you and give you the caveat that this is an unfair question. So I'll start with that because the answer is likely, it's 1,000 different things. But the question is, what causes colic? Like I said, we could be here all day discussing this, but briefly, what are the primary causative factors that we do know and understand? Because there are several things that we know are looming out there that we haven't quite got our grasp on yet. But what do we know and understand about what causes this disease state?
Sure. And I would love to answer the question, but I just want to highlight something about the last conversation and topic, and to emphasize that it's a team.
Yeah.
And I think that we have built this team that starts with the veterinarians that go to the farm. and that identify that these animals have abdominal pain early. And it's there that they make a decision as to whether it's with the owner, so that the owner is an important part of that team, whether the horse should or when they should be, how they should be treated and if they should be referred. And then ultimately coming into the hospital and knowing that it is internists, anesthesiologists, surgeons, criticalists. Like, I think the team we in veterinary medicine have now established the importance of this team in treating these patients. And I think that's why we've come so far. And then collaborations. So although Dr. Hassel's on the other side of the country, and I'm over here on the East Coast, the fact that we're talking and we're meeting at these conferences and inspired to do better and to figure out things like, why do horses colic? And having these discussions is why we've continued to get better and have better outcomes. And why it's important to say to owners that, yeah, if you invest your money in some particular cases, you will have a horse that you can ride and compete and enjoy for years to come. So I would say one of the most common causes of colic has to do with just gas, right? So spasmodic colic. So those horses can be induced from stress. And these are actually some things you can think of as people too. So what affects us? So stress. So how can we reduce stress in our horses' lives? Would probably reduce the amount of colic. And that means making sure horses were naturally meant to eat to all day long. So small amounts all day long. Sometimes that's not possible, but sometimes we can reassess how we're managing that animal and making sure that not only are we balancing their caloric needs, so depending on their effort, how much energy are they burning, and making sure that we are meeting those needs, whether it be through hay products, grain, and other supplements. So, a horse that gets trail ridden once a month probably has different caloric needs than one who's actively competing on a jumping circuit or racing, for example. And so really having that deep understanding, I think, can help to prevent colic. Trailering, bringing them to shows and competing does cause stress, even the best of horses, and sometimes they don't express it. So how can we ensure that experience is the least stressful for them? And making sure that we are feeding them in the way that they're accustomed to, that we're not introducing new things. So that's particularly down here on the East Coast, Southeast, we have issues with ileal impactions. And sometimes we think that's probably due to changes in the hay source that they get. There are some hay sources that have been associated more with ileal impaction, for example, but probably the bigger thing is the change in the quality of that hay and how that horse is chewing and processing that hay. And so I think those are probably the biggest things in preventing colic, but keeping in mind that the horse's abdominal tract is not well attached to its body wall. And there's a really cool study that actually came out of Colorado to show just how much the colon can naturally move within the horse's abdomen. And we, at a given moment, we could say, oh, well, it's displaced. Well, we actually know that might be okay if it doesn't have excessively filled with gas, it doesn't get stuck there. So it's really incredible how much we don't know about the horse abdomen, except to say that because the intestine is freely moving, it can get stuck into places it's not supposed to. And that's what ultimately causes the colic. And so, we joke about the therapeutic trailer ride. Well, it's kind of is therapeutic because the bouncing around in the trailer might help the intestine to shift back to where it's supposed to be. And so that's great when a horse comes in here and doesn't look back, there's a bunch of manure in the trailer and the horse is happy and fine. And we all celebrate the therapeutic trailer ride. So those would probably be the most common and we can probably talk about more severe causes of colic, but most common cause of colic, which I think can be managed by overall holistically evaluating how your horse is being cared for.
Diet, lifestyle, all the things to take care of these majestic animals with their so poorly designed digestive tracts, and bless their hearts. Dr. Hassel, so I want to follow up on that and give you a chance to comment to, kind of along the lines of risk and, what are some of these primary risk factors in horses that we're able to control? And what are some of the risk factors that, as hard as we try and as much as we want to, are simply always going to be present and out of our control, just by the nature of horses being who and what they are?
Yeah, sure. Well, I would say it depends sometimes on what type of colic you're talking about. So, literally, we have very specific risk factors for a variety of different types of colic. For example, like Dr. Gonzalez said, the ileal impactions and coastal hay, and for enteroliths, it would be alfalfa, large quantities of alfalfa. For epiploic foramen entrapments, it might be cribbing. There's a number of different risk factors that can play into various forms of colic. But in general, I would say dietary indiscretions, changes in diet, um, you know, um, ingestion of, different types of feed or moldy feed, all sorts of things, anything that can cause a dysbiosis somewhere in the gut can lead to colic for sure. And then there's the stress factors as well. So there's a whole host of possibilities that could all come together to result in these colic signs. And interestingly, the types of colic we see in different areas of the country are quite different in terms of prevalence. So in Colorado, we see a lot more of the large colon displacements and torsions and things like that. Whereas in some other areas, they may see much more of the strangulating small intestinal lesions, for example, or inflammatory related lesions. And so there's geographical factors also that are in play for many of these. For example, sand in sandy areas. Arizona might have more sand colics than some other places. Things like that. So just a multitude of factors that play with each specific form of colic. So
Excellent. Thank you for that. And it's tough because horses love their jobs. I think if you're not a horse person, you don't really understand that, is that horses love to go to work. They're designed to be athletes. They're designed to run and jump and compete, and they love it. But by nature, those are stressful situations. And so that would, go a long way to explaining why this is still something that we deal with all the time. And dietary changes upset them just like our dietary changes upset us. So let's kind of dig into that a little bit more, because you did mention all kinds of pertinent terms, from enteroliths to torsions to ileal impactions to strangulations. Let's kind of dig into those primary types, if you will, of colic. So my next question sort of has 3 or 4 parts to it, and I'm going to hand each of you a few of these. So we've established that there are numerous different causes and also types of colic, but let's kind of dive into it and describe a few of these and explain a few of these so we can better understand them. And Dr. Gonzalez, I'm going to start with you. Let's talk colics affecting the small intestine. So we're talking things like the ileal impactions, the strangulating lipomas, etc. School us a little bit here, if you would.
Sure. Yeah, absolutely. So, so we're talking the worst, so causes of colic, the ones that have some of the worst outcomes, tend to be associated with the small intestine. And they could even range from non-surgical, like an enteritis, so an inflammation throughout the entire length of the intestine. But ultimately, the intestine and the small intestine is very sensitive to a loss of oxygen. And that actually I wanted plays into the last question, because with our athletes, the intestine is not a privileged organ. So when we are taxing our bodies and we are undergoing exercise, the blood ends up getting shunted to other parts that are privileged, like our hearts and our brains and our big muscles. And it goes away from the intestinal tract, which actually can contribute to cramping. And I know I have experienced that. I'm not sure. I'm assuming that Dr. Hassel has also experienced that. And so, in general, when we talk about, oh, my hand just raised up. Um, when we talk about the small intestine and strangulation, or ileal impactions, there is a reduction of blood supply to a segment of the intestine. And then that is called ischemia. And when ischemia happens, there is a progressive loss of the lining of the intestine. And that lining is really important because it prevents the noxious bacteria and toxins that we normally have within our intestinal tract, we all do, from passing from the lumen to the inside of the intestine and having access to our systemic circulation. And so once that barrier is broken down, then we developed complications like SIRS and laminitis and things like that. And so whether it is a strangulating lipoma, whether it's an epiploic foramen entrapment, ileal impactions less so, but it can cause just the distension of the intestine for an extended period of time, can damage, do a similar type of damage, even though they tend to be able to be corrected without resection, without cutting out a segment intestine. But ultimately, when a segment of small intestine is so compromised that we don't believe that it would heal on its own if we kept it into the horse's abdomen, we cut it out, and that's called a resection. And then we reattach the parts that look healthy, which is called a anastomosis. However, everything oral, so ahead of that. So unfortunately, a lot of these things tend to occur at the end of the small intestine, right before it enters the cecum. And so everything ahead of it has been distended and can be really, really big. And I talk about that when I'm explaining it to owners, like anything that gets your clothes, if it gets stretched out for extended period of time and then it can't go back to its normal size. And so what can happen specifically with the small intestine is it suffers from ileus after we experience this. And that is that it no longer can contract appropriately to pass the food from the front to the end where it enters the cecum. And so those horses tend to reflux. So some of the major issues that we deal with specific to the small intestine when it undergoes an ischemic event.
So interesting. I mean, scary and interesting at the same time, but there's so many little nuances to each of these different types of colic and the things that you all have to deal with on the table, let alone the things that veterinarians in the field, that are going to be the ones referring to you or dealing with in the moment as well. So very multi-level, very complicated. And I feel like, potentially the small intestine and colic affecting the small intestine really highlights what you were saying, Dr. Gonzalez, about the team, because the risk, especially of endotoxemia in these cases and everything that these anesthesiologists are doing to manage that on the table in these cases, it's just amazing, and how far that area of medicine has come. I think really is a testament to the progress that's been made in colic and especially, achieving more successful outcomes for these patients.
And the criticalists that are stabilizing these horses before we take them to surgery. So I think beforehand, we might rush an animal directly into surgery and then the anesthesiologists are managing it. But now in many institutions, we have criticalists who stabilize these animals. There's a balance. Sometimes you just have to go and you just have to take them to surgery and get it fixed. But I think we're better also at stabilizing them. And I think Diana could probably respond better to that since she is a criticalist.
Diana, what say you?
Yes, I agree. Very a critical piece is that stabilization, to some extent, depending on the lesion, because time is also of the essence. When you have dead bowel, for example, from a strangulating lesion, the the most therapeutic thing to do is get that out of there, as long as they're stable enough to withstand the anesthesia and recovery. Recovery is also another big factor as well. So
I have to say, I've always really admired Dr. Hassel's even-keeled demeanor because I always think of criticalists and I'm like, do y'all ever have a tranquil day at work? Like, is it ever not DEFCON 5 stressful at work? And I've always been very impressed with how you handle that, Dr. Hassel. And I want to come to you next because we talked about the small intestine. But what about the large colon? Things like displacements and torsions, among others. What are you facing with these types of colic?
yeah, so I generally like to classify colics into whether they're non-strangulating obstructions, or strangulating obstructions, and this goes for small or large intestine. Or are they an itis, so an inflammatory condition? Because those can look a lot like a colic, or they are colicky in some situations, even though their primary disease is inflammatory with diarrhea or refluxing or that type of thing. And then also infarctive disease, which are a little less common, but we do see those as well as a cause of colic. And for the large intestine, examples would be non-strangulating obstructions, would be your basic feed impaction. So super common, probably one of the most common conditions we see out in the field when your horse stops passing manure, that goes out to treat and gives a laxative and provides a little fluid, gets a little pain control, and they start passing manure after a period of time. And then enteroliths would be another example. Sand impactions would be another. Displacements without compromising the blood supply in a large intestine would be another example. And on the strangulating side, we have probably the biggest one would be the large colon volvulus. There's also some forms of intussusception and so forth that we'll see, but those are pretty rare. We can see cecal torsions as well, which is like the appendix for a human, but much, much bigger in the horse. Those contours as well. And so those are probably the big things that we see with regards to the large intestine. There's also the small colon, which is still part of the large intestine, which can have its own conditions as well. So usually similar. The torsions are pretty uncommon there. And then Dr. Gonzalez mentioned small intestinal strangulating lesions. We see a lot of strangulating lipomas, which are those fatty tumors on a stalk in the small intestine. Occasionally, you can see those in the small colon as well, but usually they don't strangulate the large intestine. And then occasionally the infarctive lesions, where you have a focal region where the bowel has lost its blood supply. It could be venous or arterial or a combination. Could be like typically we might see on ultrasound a focal area of marked thickening. If it's advanced, it might actually be thin-walled and about to just blow out into the abdomen. So those are the big things that we see.
Why can torsions be so complicated in particular?
They are so difficult to manage because once they become advanced to the state that all the tissue is non-viable, first of all, it's a huge surface area, and the bacteria present and other all the components of the lumen that are within the lumen of the large intestine aren't meant to be exposed to the systemic circulation. Those bacteria and their cell walls and the toxins and so forth are not friendly to the animal once they've been exposed to it, and can result in pretty severe life-threatening complications. And for the large colon volvulus in particular, it tends to, for the most of them, tend to twist at a location that is very difficult to access. And so it encompasses the entire large colon all the way down to basically where the cecum and the small intestine tie in, the base of the large colon. And so getting all of that out can be impossible sometimes to do safely without spilling intestinal contents everywhere. So they just we still have difficulty with those really advanced large colon volvulus cases where the bowel is completely dead, stem to stern, for the large colon.
And just a short, you don't have a whole lot of time. So
Yeah.
after they twist tightly,
Mhm.
intestine dies very rapidly.
Yeah.
So, we know that less than 3 hours really, which if you think about, for us in North Carolina, it could be hard for somebody to get from their farm to us. By the time they get somebody, the referring veterinarian to come out to evaluate the horse and then get it on the horse trailer and bring it here, it can take longer than 3 hours, and it usually does. So I think that's another particular, because it can twist so tightly,
Mhm.
and it extends and involves so much of the colon.
I actually think it can be helpful if they have a impaction present concurrently, which may have led to some of the gas buildup and then things flipped around and that type of thing. Sometimes I feel like that might be somewhat protective to the vasculature. And so they can be twisted for a longer period of time sometimes and still not be totally non-viable. Just an observation, but I don't have concrete data on that.
You've only cut a few of these in your life, so I think that counts. Yeah, that's so interesting. And 3 hours is nothing. I mean, not as rapid fire when we're talking about that much time that it takes to get your veterinarian out there, even if they're running to your farm and then get them on the trailer and get them to the surgery center or referral hospital. It's a tight window. So Dr. Hassel mentioned enteroliths. Dr. Gonzalez, I want to throw this one at you. First of all, what are these extremely alien, odd golf ball to what large grapefruit sized? I have round stone. Do you have them? Oh, you do. I can see.
Yeah, there were a couple more in that horse that I gifted to everybody on the table.
Nice. Well, for those of you who are listening and not viewing it as a webinar, yes, she really does. She has some of these enteroliths sitting right in back of her head. So how do they form? How do they contribute to colic? What are these things? And not all of them result in colic, which I think is really interesting because you would think the larger, the scarier. But I feel like when they hover somewhere around, the size of a baseball or so, you're worried about a certain size range more so than you are on one side or the other. So explain these things to us because a lot of horse owners will find these in a stall, smaller ones and be like, what in the what is this?
Yeah. Yeah, so Dr. Hassel mentioned about the association with alfalfa, and we think it's the high calcium content, the mineral content, but we believe that it's some nidus, so that it forms around some nidus. So the horse ate something that now these minerals can sort of attach to and grow. What's interestingly is usually there's not one. I definitely have cut horses where there's one. If there's one or if there's not one, you can see, I think there's a flat surface on that one I can kind of make out. So when they're not perfectly round and they have a flattened surface, you need to go find its buddy. Or in this case, it had multiple buddies. And so the likelihood is that there was some type of nidus. There's a high mineral content within what the horse is consuming. And that ends up forming this mineralization. And then just keeping in mind that the horse's colon, it's large in certain areas and then can get very small. And so the size comes down to whether there is a blockage when the size of there's particular areas, a transverse colon is a common area because the colon gets from large to small there. So if that anerolyph, that mineralized material ends up entering the transverse colon, it's more likely to get stuck there just because of the size disparity between the large colon or that portion and the transverse colon. Sometimes it can pass through the transverse colon and get stuck in the small colon. But again, the diameter is where the issue is. So it's the ratio between or the size of the rock and where it passes and whether or not it can or cannot pass easily or if it's going to get stuck. So when it gets stuck is when we end up the colic. And it's not even necessarily at that site. It's that everything builds up behind it. And so then that horse gets gassed up or maybe displaces, or so it's because in some of these cases they can be intermittent. So they can colic intermittently. It's not necessarily, and many times it's not boom, your horse comes in for colic and it's, definitely an enterolith. Usually there has been a history of some degree of colic leading up to that, then all of a sudden goes away because maybe it, pops out from where it was. We don't totally understand, aside from what ultimately causes them to need to be referred to a tertiary care facility for surgery, which is it gets stuck. What the discomfort is associated with the stone within their colon.
So wild. I mean, they really are interesting. I was going to say interesting little things. They're not really that little in a lot of cases. So very interesting. Thank you for the lowdown on that. And thanks to you both for those answers. I feel like it's a little bit unfair because even in discussing those major types of colic, we're still missing, so many less common types. But in the interest of not taking our listeners on a 3-hour tour today, let's switch gears and talk treatments. So, Dr. Hassel, talk to me about the surgical advancements in particular that have taken those survival odds, that we mentioned earlier, from 0% to past 90%. What has come about and allowed surgeons like yourselves, to operate these horses more successfully? And I'm sure that includes innovations, in technology and instruments and suturing and anesthesia and all the things. So what's progressed in decades of late?
Yeah, I would say a lot of it has to do with just improved training through years of experience from individuals and the development of superior methods like for suturing, for example. I think for small intestine, a really critical piece, there's so many potential errors that can be made um, when doing a small intestinal resection and anastomosis, say for strangulating a lipoma or something like that. And I have to credit Dr. David Freeman, for really being a pioneer in this area in terms of really educating surgeons as to methods to optimize the luminal diameter, for example, in these cases, and avoid common mistakes that lead to blood supply issues to the anastomoses and things like that. He's really done an amazing job at educating veterinarians in this area, and actually does a annual workshop to train veterinarians to the more advanced techniques. And so it's people like this and just a lot of great surgeons that are training other surgeons to and also being open-minded to adopt changes that maybe are better for what you've been doing for the last 20 years. I think all of those things kind of contribute to, as far as the actual surgical procedure, having better outcomes, techniques for blocking, contamination, things like that, that are just shared among surgeons, I think really make a difference in the long run. So.
Yeah, and I think that this is an area where you see the research having a significant impact, but also, the daily hands-on horses in the OR performing these surgeries and, what you all are learning from each other by the actual doing, the day-to-day. So I think it's amazing how far it's progressed and continues to progress. And I'm sure meetings like the Havemeyer, where you all get together and talk about best practices and what you're seeing success with, makes a big impact, and can be shared beyond that. So I love that. Thank you. Dr. Gonzalez, these cases are equal parts. I feel like the in the field veterinarian, the first person on the ground when these are happening, to surgeons like yourselves, conducting the surgeries, getting them through a successful surgery, but then the post-operative care, I feel like, is a place that's seen a lot of advancement as well. And it's kind of wild when you think about it. I mean, these horses that you just operated have had major abdominal surgeries, and there's this huge incision most of the time that's now holding this large volume of intestine and fluid and all the things. So, how are you and your team working to take care of that wound and make sure that it's able to not just support the weight of what it's holding, but also you're simultaneously working to prevent things like infection and gut dysbiosis and colitis and helping these horses to resume gut motility as soon as possible. So there's a lot that goes into this post-operative care. Talk to me about this, because this is an area, and Dr. Hassel's shaking her head right now because she lives in this world every day too. But this has seen a lot of improvement, right? So you're seeing more successful outcomes because of what happens after surgery, not just in surgery.
Right. Yeah, and I'll start with the incision. I mean, there's actually been a lot of research just in how to appropriately, the most effective way of closing the abdomen. You know, you might think that the more suture, the better, or the closer the suture is, the better. But actually, we know that there's a appropriate distance between the suture bites. We know that even opening the abdomen, right? So we know that a sharp dissection down, one single sharp dissection down is much better than you have to lift your scalpel blade and do multiple cuts, because you're creating multiple wounds that's harder to heal and potentially provides more spaces for bacteria and things to grow. So the incision it almost seems like maybe the simplest part, but it's not, of the incision. And I think we are more particular about every stage of the surgery, to the number of times that you put your arm in and out of the abdomen actually can traumatize the incisional wall. So I think as surgeons, we've become much more particular about how we close the abdomen, the type of suture that we use to close the abdomen, the number of knots that we use, because the more knots that you have in there, again, the more foreign material that can create issue. I think there's still debate as to the best way to cover an incision. So I won't necessarily, I have my preferences, but how long the incision should or shouldn't be covered. Should horses be recovered with belly bandages or not? What type of belly bandage to use? These are all discussions that we are continuing to have, and it might depend on the location and your recovery stall. So, but just the awareness that these things matter, I think, has helped to improve how the animals recover. I think one of the biggest things in my career thus far has been our appreciation for managing pain. So I think we're much better. We know now, we have a much better appreciation that pain disrupts healing. So the horse is going to heal better if we reduce its pain. And I think we're much more aggressive about pain management, continuous rate infusions of different types of pain meds, keeping in mind what we use that don't halt motility. But just being much more aggressive about the type of pain management of these horses, I think, is helping. Appreciating that if the horse you have to balance if the horse is refluxing. So does it have progressive motility? But food, the stimulation of eating and swallowing is actually really important to signal to the brain, which then signals the intestine to create motility. And I think some of us are much more aware about the type introducing food orally earlier than we might otherwise have, and how we manage that in order for the horse to recover faster. Also, we might supplement them intravenously with nutrients and things and calories, because again, in order to heal, you need energy. So the body and the horses tend to be in a negative energy by the time they've made it through colic surgery. And so making sure that we are providing the energy sources, whether it is through intravenous routes or maybe earlier, having horses go out and even smelling grass. And we sometimes use nibble nets. So maybe they really don't feel like they can eat. But the stimulation of trying to get a little bit of food or a little bit of grass, we know these seem like simple things, but I have watched over my career how we have been more active and aggressive about introducing these things that ultimately I do believe help these horses recover. And like I said, the big one for me that I feel like is pain management. I think we're much better at pain management and we are continuing to try to improve that area of research.
Yeah, and I want to ask that question over to Dr. Hassel too, because I want your thoughts on this. But one thing you said was interesting to me because, growing up under Dr. Doug Herthel, he also was a big proponent, I think way before it was cool, to say these horses have got to start eating as soon as possible. In every case, no. In a majority of cases, yes, and that didn't used to be the way that it was done. But now it seems to have such a positive impact because of that gut motility getting going again. It's nature taking over and doing what it's supposed to be doing. So Dr. Hassel, I want to turn that over to you so you can comment as well.
Yeah, I would reiterate, well, of course, the early enteral nutrition is critical, but the pain management piece is really advanced a lot in the last just maybe year or two. From probably the newest techniques that have been described are the celiac plexus blocks, which aren't in regular use yet. They're still kind of being used in more research and clinical research settings. But that has the potential to improve motility as well as reduce pain. And then we're routinely now in our clinic using intercostal nerve blocks. So we're trying to block all that severe pain of the major abdominal incision to improve recoveries for these horses, which sets them up for a better start to their post-operative period. So if you're in horrible pain and you have a horrible recovery and you've thrown yourself all over the stall and your lactate is 17 or something, that's going to set you up for failure to start. So these pain management techniques that have really been a key part of these cases, I think, has made a big difference. And then, of course, the fluid support, we've learned a lot and made advances in optimizing, blood volume so that it's not too much and not too little and through our monitoring techniques. And, of course, giving that early enteral nutrition whenever possible. And if it's not possible, parenteral nutrition, so giving nutrients through the IV line might start with just dextrose, and then it may advance to more complex solutions. But those are some of the big ones. I also routinely will put, since these horses are always on perioperative antibiotics, I'll usually put them on a probiotic as well, just to support gut health in general and reduce that risk of antibiotic-induced colitis because they already have a compromised GI tract. So,
yeah, I love that. Obviously, we're proponents of that as well. But, and I wanted to ask you, Dr. Gonzalez, about a couple things, and they may not be quite as common. But what are some of the complications that you're looking out for in terms of postoperative care? So whether it's skin infections or, something that is beneath the surface, which is obviously what you're not wanting to deal with, or something that might be a little less common, but a little bit harder to manage, like septic peritonitis or even adhesions.
Yeah, so it depends on the colic. I mean, any of these things can probably occur with any colic, but we know that if resection anastomosis is required, the likelihood that you might have an incisional infection increases. If you have to bring that horse back to surgery a second time, the likelihood of an incisional infection increases. Anytime we have strangulating intestine, we are concerned overall with if it's small intestine compared to large intestine, more commonly ileus, so reflux. So the horse just then can't eat very much and just, we have to pass a nasogastric tube to relieve their stomach. But then things like infections at their catheter site. So can happen just again because we both alluded to this idea of the toxic material in the intestine. Anytime you've had a strangulation or compromise of that inner lining of the intestine, there is a leakage of those toxins and bacteria systemically. And that can hit lots of areas. It could hit the catheter site, which would cause thrombosis of the vein. Some horses get laminitis. So it seems very far away from the intestine, and yet these horses can develop laminitis or inflammation within their hooves. And so, these are complications depending on I think, more common with the more complex colics. And if we're talking about a displacement, a lot of these horses, we really don't have much issue. We replace the colon back where it's supposed to be. The incision doesn't have to be that big sometimes. And they come back and they're fine. So it honestly just depends. There's a spectrum, and that spectrum of complications, we know there's more complications the more complex and compromised the intestine is in colic surgery. But in those ones where there's a displacement, complications can happen, but they're much, much less common.
Excellent. We love those. Perfect. And Dr. Hassel, I want to circle back to a comment that you made, and that was on the microbiome and the probiotics, prebiotics. And I want to give a little attention to the work that you've done on the microbiome throughout the years, because, it's so interesting that the gut microbiome really comes into play before a colic as a potential causative factor or even preventive factor. And it also comes into play after colic surgery in your efforts to repopulate that horse's gut microbiome that's very often, literally flushed out during surgery. So what is this buzzword, the microbiome? We hear it a lot now. And why is it so important both before there's ever an issue and also after you've surgically treated a horse for colic?
Right. And microbiome, of course, is just as critical for horses as it is for humans and any other mammal, right? So you are what you eat to some extent. So we want to keep the bugs. We have more bugs in our gut than we have in our entire body. And they are critical to the functioning of every aspect of our body, our nervous system, our immune system, anything, you name it. That what's in your gut is connected to how your health is in general. We know from studies in horses that the peripartum mares that develop large colon volvuluses and displacements have differences in their microbiome than the ones that did not develop signs of colic. And that's a common condition we see around that postpartum period where the colon flips, probably related to not only those pre-existing microbiome changes, but the management changes that are associated with having a baby and then producing milk and changing, their caloric intake and maybe bumping up grain intake, for example, might produce more gas, things like that. And so we certainly identified those as risks, things that occur. You can't just take a sample and analyze it and say, is my horse at risk of colic? Right now, we're not at that stage, but we know that there are changes that occur beforehand that lead to that. And similarly, after colic surgery, we know there's considerable changes to the gut microbiota, especially when we are putting hoses up there and rinsing out impactions and, flushing out much of the ingesta within the intestinal tract. That needs to repopulate in a healthy way and hopefully minimize the potential for continued inflammation, continued disease states in the post-op period. And so that's why that repopulation with having early enteral nutrition is really critical. So really that hay and the fiber from the hay is really an important piece, getting that back into the hindgut so that the normal healthy microbes can start fermenting that fiber and produce some a more healthy environment is critical. And then in addition, I've done studies with both with probiotics and prebiotic in assessing the impact on exposure to antimicrobials. So these horses are also getting antimicrobials for variable amounts of time, sometimes just a few doses, sometimes 3 to 7 days, and depending on the case. And and in my studies, I've shown some beneficial impacts of probiotics, which dramatically changed what is called the metabolome. So not so much the microbes, but it did alter the um, the small molecules produced by these bugs, essentially, in a positive way that more closely mimicked before exposure to antibiotics, which are generally going to be detrimental to your gut microbiome. And similarly, using rice bran had some positive effects on diversity of the gut flora, looking at fecal samples before and after in these cases. So there are things you can do nutritionally to um, help reverse some of these negative impacts that colic has on the colic surgery have on the GI microbiome.
So fascinating. I mean, it's like nature knows what it's doing, and no, it's so interesting. And I think the study of the microbiome and the metabolome and all of these things is so evolving, and we don't know what we don't know yet. I mean, it's this vast ocean of possibility, which is one of the reasons veterinary medicine is so fascinating, is because there's so much more to explore and there's so much more to learn and to apply to the horse to get these incredible outcomes that we're always looking for, and but we do know that diversity in the microbiome is typically linked to healthier horses and healthier GI tracts. And we do know that the balance between beneficial and pathogenic bacteria has to be there. You have to have enough good bugs to combat bad bugs.
Exactly.
And so when you break it down, while it is vastly complicated if you let it, there's also some simplistic points to it too, that aren't super hard to apply and understand, for the horse owner and lay people like me. But thank you for that, because it is a fascinating area of study, no doubt. And, as we kind of start to round down, I want to ask Dr. Gonzalez about something, because we've mentioned this term a couple times in this discussion, and that's reflexing. And it is something that's unique to the horse versus the human. So why is this a complication in horses? What causes it? And how are you handling this?
Right. So reflux is basically the horses cannot vomit. And so when fluid builds up, when their intestine doesn't effectively move, so the small intestine is normally full of fluid. All the water actually gets absorbed in the colon. So the function of the small intestine is to absorb nutrients, and so the content is usually pretty fluid. It's just fluidy until it gets to the colon, and the colon absorbs the water back into the body. But when the intestine, for whatever the reason, doesn't efficiently move that fluid down into the colon, it gets backed up, it goes into the stomach. And now that horse can no longer, the stomach just gets big, and we can actually get gastric rupture. So the way that gets taken care of is we pass a nasogastric tube. So the nasogastric tube now creates a conduit to relieve the pressure within the stomach, and we can get that fluid out. And that makes the horse more comfortable. For one thing, it prevents gastric rupture. And so, many times that's one of the first lines that a referring veterinarian, when they go out into the field, because it actually can also be diagnostic. So, and I'm not sure we have necessarily time to go into that, but it is one of the ways that we can help differentiate sometimes whether it is an enteritis or primarily inflammatory process, or whether there's an obstruction that's causing that fluid buildup and that reflux. And then ultimately, the reflux that we get post-operatively, that's very much associated to what happened, how distended was the intestine, how much did we have to manipulate that intestine intraoperatively, which can all cause issues with the signaling that controls motility. And it's not just any motility. It's not just, make the intestine small, make it big. It actually has a functional waves that help the intestine so that it moves it in from one direction, from the most oral part to the most aboral or away into the colon. So that's what causes reflux and motility issues, basically. And passing a nasogastric tube, one of the most core central parts of being a horse vet.
Lucky you all.
AI can't do that.
AI can't do that.
AI cannot do that. I think y'all's job is safe. Okay, Dr. Hassel, I want to rewind for a minute. And this is to a vital step that both of you and Dr. Gonzalez brought up earlier. Vital step in the process. So before the horse is ever laid on your table in the surgical suite, it's diagnostics. And man, is this a multifaceted piece of the puzzle. So how do you know? How do you know when a horse needs surgery? I feel like nearly every horse owner has been there, in one form or another. We're holding a lead rope as our horse is being tubed in the field, hoping that colic symptoms will subside and things will get moving with medical intervention alone. And that our horse will not be a surgical case. But as a veterinarian, what diagnostic tools are you using? What vitals are you monitoring? How do you know when to call it and load that horse on the trailer? And also, why is time really of the essence here? Because we've talked about the time factor in several specific cases, but in general, I mean, this is an area of veterinary medicine where time counts. So for these referring veterinarians, when are they making the call? When should they be making the call? And why is time so imperative?
Yeah, there's so many questions in there. So,
I know. So if we could just start with lower, start to finish, that'd be great.
yeah. Let's start with the last one. So the time component. Of course, if you have a surgical lesion in a horse, the earlier you can get them to a surgical facility, the better. And the big question is this a surgical lesion? Because it's a big investment, right? It's a big investment for the client to head to a surgical facility. So you don't want to make that error of being too aggressive when the horse would have been fine. And so really looking at those in the field setting, a lot of it ends up coming down to gut feeling, but I think really critical factors are going to be pain level, response to analgesics, and looking at the physical exam signs. Your rectal exam can sometimes be fully diagnostic of certain conditions as well, that may or may not be surgical. So, for example, a severe cecal impaction, you don't want to sit on that, or just a profound gas distension where you're suspecting a volvulus accompanied by pain. You don't want to sit on those things. So it's just a combination of mostly your physical exam findings and the response to analgesics. And really in the hospital setting, the response to analgesics is the number one reason we take a horse to surgery. Sometimes it's what I see on my ultrasound probe the moment they walk in, but some in general, if you're not sure, if you're taking in a horse that has mild discomfort or moderate discomfort, and you're not sure, there's certainly a whole host of diagnostics that we really rely on to help us in the decision making. Those being your physical exam findings always are important. And as I mentioned, the response to pain meds and a change in that response. So let's say you give a particular dose of pain meds, and you get pain relief for 30 minutes. If you repeat the same dose and it doesn't give you any pain relief, that horse is going in the wrong direction, and probably needs surgery in order to correct it. And so more commonly, we're doing heavier drugs that are lasting 2 hours and then they only last 1 hour, and you're like, okay, time to go. So but that's a big one. And then of course we're trying to find a diagnosis. That is the key thing. So if we can get a diagnosis through our rectal exam, through our ultrasound of the abdomen, through our blood work, through our physical exam findings, all of those things combined. We hope in most situations, we feel fairly confident of what is going on. And certain things are surgical and others you can kind of ride them out and try to manage them medically. And we will, as long as we can, while not compromising the horse. And then, of course, the abdominocentesis is another critical piece for many of these horses where we're not 100% sure if it's a surgical lesion or if we want to gain more prognostic information. Not sure if a horse has ruptured its intestinal tract or something. So confirming a diagnosis, that is another critical piece. Those are the big ones for the acute colic that we commonly use.
I remember Dr. Chad Davis, who practices back in Virginia, always says, he's like, I'm not out to be a hero. If there is any question whatsoever, like, it's getting loaded in the trailer and sent to the surgery center, because it's not a guarantee they're going to cut this horse, but they're going to have the resources there to deal with it in a hurry if it needs to be. So
that's our favorite referring veterinarian.
Right? 100%. Don't be a hero. Something that you said brought up a question, and that's analgesics and using them in the field. Is there caution that needs to be taken or anything along those lines in the field? Can you do more harm than good if you're administering it and potentially drawing out this process where you could have made a quicker decision if symptoms might not have been masked?
Absolutely. And not so much masking surgical symptoms. I know that's always out there as a concern by giving too potent of analgesics. But I worry more about repeated doses of Banamine, for example, in a horse that's sick for any period of time. I think you're putting those horses at risk, especially for their kidney function. And you don't have, obviously, the more potent drugs like xylazine and detomidine and butorphanol and so forth. Going through, most people are pretty good about recognizing when a horse is not responding to those more potent analgesics. And so I'm not so worried about those delaying the onset or the referral in time as much as the repeated doses of Banamine personally. Usually you can tell when you have a horse with colic that's progressing or colic that's fairly severe to start with. Those horses are ones that you shouldn't delay regardless of their response.
Excellent. And, Dr. Gonzalez, along those same lines, is there anything that you wish horse owners and even referring veterinarians in the field took into consideration from a surgeon's perspective in terms of the things that can be assessed and decisions that can be made in the field that can increase a horse's chance of a successful outcome if surgery does, in fact, need to be required?
Yeah. I just to emphasize, despite being a surgeon, that we want the best, we have the best interests of the horse in mind. And if surgery is not required, we all recognize, we do make quite an effort when a horse comes in here to prove us wrong, to say this horse actually doesn't need colic surgery, because we understand even in the simplest colic surgeries, it's still a major event. Both financially, but also for the horse. And then, if you had aspirations for competition. So most of us, I think we all really appreciate the impact of that. And so, out in the field, it's having conversations with the owner to understand all of the options and laying it out there, talking through what you're thinking. When it comes to diagnostics, and understanding that it's a black box. I mean, there's a whole lot in there, and sometimes I've definitely taken horses to surgery purely based on pain. I had no idea. Like the rectal exam was negative. The diagnostics were relatively benign, but the horse's abdomen was so big that the issue was compartmentalized. And so it wasn't showing up on the abdominal centesis, on the belly tap. It wasn't showing up on the systemic blood. It wasn't showing up when my arm was in the abdomen. I couldn't find it on ultrasound. And it purely was pain. It purely was, I could not control this animal's pain. So just to say that, sometimes we don't know, and that's okay. And if an owner is on board and they understand that what's their expectation is when they're getting to the referral hospital, that it does not mean that surgery is going to happen. It might be the recommendation, but it might not be. And that at the tertiary care hospital, we have more tools. We tend to anyway, have more advanced ultrasounds that can go a bit deeper. We have a battery of things that we can more thoroughly evaluate the blood work and the diagnosis. We have pathologists that can look at abdominocentesis and blood work and things like that. And so we just have a expensive team that can help us to narrow down. We've got this list, and the same list that the referring veterinarian probably had, that maybe we can narrow down because we just have these resources that are available to us. So communication. It's a team, and it continues to be a team even after the horse gets referred into the hospital. So just really having owners understand that we very much are at this, and having their input is just as important when making some of these decisions as to whether the horse goes to surgery, or maybe even what we do within the surgery suite. I actively talk to owners. There are options. And I try and communicate as effectively as possible so that the owner can make the best decision for them and for their animal.
100%. And sometimes surgery is required, but I think that's important for owners to know, is that just because your horse goes to the surgery center or goes to the referral hospital doesn't mean necessarily that surgery is going to happen, but it is there to step in when it's needed, which is nice. So I have one more question for each of you. And first, Dr. Hassel, I want to come to you because we touched on diet a little bit, but I want to zero in a little bit more on that. What role can diet play in increasing a horse's risk of colic? You mentioned a few things, but things like overfeeding grain, feeding fewer large meals, and perhaps not necessarily paying attention to creating a varied microbiome. So what role can diet play in the causation of colic, but also what role can diet play in helping to maintain a healthy horse, and a healthy digestive system? Because we don't want to be here. We don't want to be talking about colic. So as much as we can do to help keep the horse healthy, the better.
Yes, absolutely. I think diet is probably the number one factor that contributes to these various GI disturbances, essentially, whether it starts with gas production or it starts with inflammation. I think changes to the diet, of course, as Dr. Gonzalez mentioned earlier, are very critical because they're delicate creatures. They're big, but they're delicate. And you can't just change their food from 1 second to the next, or throw them out on a grass pasture when they haven't been grazing. And so they need to adjust slowly into any changes in their diet that are taking place. And some horses also just have difficulty with production of gas. And so many of these chronic colicers, we see a lot of recurrent colics. In fact, that's the number one complication of any colic in general, is colicking again in the future. Whether they have surgery or not, they're at high risk for colicking again if they've been managed aggressively by a veterinarian for colic at any point. And so one approach that I've taken in recent years has been moving to a more what's called a low residue diet to see if we can reduce some of the gas production associated with maybe trying to deal with these super fibrous, maybe less energy dense type of lower quality feeds, and sticking with a more like ground up or pelleted feed, providing Other nutrients, omega-3s, for example, are always going to be a beneficial addition to the diet. The appropriate vitamins and minerals that they need. And then, but the low residue diet, I think we've had some success, but we don't have data on that yet. There is some early evidence that may be helpful for some of these high gas producers that keep displacing their colons. And yeah, generally speaking, that nutrition is everything when it comes to health. Not just for horses, as I mentioned, for people as well, and all of our pets. And so, having a good balanced diet, some diversity in there, can be beneficial, but you also want to keep it very gradual with any changes, and adapt to what your individual horse needs, because I think some horses do have sensitivities to certain types of feeds and so forth. So it may be a little different from horse to horse, but again, that continuous feeding is of course more ideal, just like the horses in the wild. We rarely have issues with those horses that are just out on pasture all the time. But again, hard to achieve in the various climates, right, that we're in. So,
Yeah.
yeah.
100%. We've got some variation in geography and in feed quality and on all the things. But no, I think that's so interesting and so true, right? We're dealing with these giant, majestic, powerful beings who are also very delicate and temperamental in what can irritate their digestive systems. So, all great points. And Dr. Gonzalez, I want to round out with you. What's next? Talk to me about what's next. Some of the advancements that may be making their way into veterinary hospitals to treat colic, and some of the work that you're doing focused on things like intestinal stem cells and enteroids. I mean, it's pretty cool stuff. Share a little bit if you would.
Thank you. Thank you. Yeah. I mean, I have to say the here and now, I think both Dr. Hassel and I said pain management, and just the more novel approaches that have come out, whether it be local blocks, as a really good example, intercostal blocks, things like that. So I think those are some pretty cool recent advances that have made a big impact. Um, One of the big things that we talked about, early diagnosis. So there's many people who have been interested in biomarkers. So how with biomarkers for early intervention, so to help a referring veterinarian maybe to say, yes, this horse is in fact colicking, to biomarkers that could differentiate whether it is inflammatory or whether it's strangulating. Because again, most of the inflammatory ones we can treat medically, and that horse does not need to go to surgery. But sometimes they can be hard to differentiate. Even under the best of circumstances, they can be hard to differentiate. So in my lab, we have working on coming up with specific biomarkers that can help to differentiate between inflammatory and strangulating types of colic. The stem cell work I've used to help determine viability, so intestinal viability. So will this intestine heal? Will this horse recover? Because these owners are investing a lot of time and a lot of money, and I would love to be able to tell them tableside that your horse will survive. And so one of the ways that I have done that with my research is looking at the viability. Are their stem cells still present, and are they proliferating? And if they are, the intestine actually has this amazing capacity to regenerate. That can also help our surgeons, because our surgeons might be able to say, in fact, the intestine might not need to be resected. And if we don't need to resect it, then the length of surgery is much shorter. We don't have an anastomosis that could potentially have a stricture or leak. So there are so many opportunities here with regard to looking at intestinal viability. And I'm doing that. I've done that looking at specifically at stem cells. And then the enteroids and organoids, they're a great way for us to test therapeutics. So the reality is that, it's hard to come up with new therapeutics and to see whether there's an impact. And these enteroids or organoids are basically the inner lining of the intestine. It has all the cells that the inner lining, including the stem cells of the inner lining of the intestine, and they grow in a dish, and we actually call them mini guts. And they're really beautiful if you haven't had a chance to take a look. So I would encourage you to go down to Google and might even look at mini gut, it might come up. And so it's a nice way that we can test things without testing them directly on horses. So we can test it in a dish and we can say, yeah, this is likely to help the intestine repair itself. And so then it's worthy and it's valuable to now try in horses and see if we can have an effect. The only other thing I'm going to say is that this is sort of hot off the presses, but we have a machine that I can maintain, the team can maintain a segment of intestine for a period of time. It's actually been published before, but we're actively using it in the lab so that we can test some therapeutics that can be given within the blood supply to the segment of intestine, and it can also be given within the lumen to try and both. So using the system, we're creating a controlled injury, and then letting the intestine repair, and we're going to apply different therapeutics. So the sky's the limit. It's been pretty exciting road doing advancing research in the area of colic, and I'm really hoping that my goal is that these things can be applied sooner than later to the clinic to help treat our horses more effectively, and also to help us, because ultimately diagnosis. And so keeping that in mind, there's many people who are looking to try and find better tools to help, or both referring veterinarians, but also those in the hospital, that so we can more effectively diagnose horses and determine the intestines' viability.
If being a veterinarian wasn't cool enough, you get all of this amazing science that you all are working on that, I mean, is really going to take this to the next level. And something that I love that you said is you talked about biomarkers. And this is an area of veterinary medicine, one of a few areas of veterinary medicine that is changing things, from making it less and less reactive and making it more and more predictive and preventive and personalized to each of these horses. And I feel like when those things, predictive and personalized and preventive, when we focus on those things, outcomes often improve. And so I think that is really interesting. And I know Dr. Hassel has some colleagues at Colorado State that have been doing amazing things with biomarkers and predicting orthopedic injury. And there's just a lot going on there. So I would encourage horse owners to constantly be thinking, in wonderment. We have so many amazing tools and smart people now, but just wait. There's more on the horizon, and there's a lot to get excited about, in colic and in so many other avenues, from soft tissue injury to orthopedics to so on. Big things are happening. You all have a lot cooking at any given time, so it's highly impressive. And, Dr. Hassel, I want to turn it over to you for any closing thoughts. I think you've had plenty of fantastic thoughts, but anything to round us out on this discussion?
Yeah, sure. I just want to say that really the key is knowing your own horse as a horse owner, and being proactive, trying to optimize their nutrition, and prevention. I think is the number one thing I think that we need to be focusing on right now from the horse owner perspective, and that's a tough one. It's hard to prevent some of these colic situations. And so we do the best we can once it occurs. And I think it's been a wonderful, the last 20, 30 years have been amazing to see the advancements that have taken place in management of colic. And I'd like to see the same in prevention as well. So I think that's our future as well.
Absolutely. Couldn't agree more. And there you have it, ladies and gentlemen. We really could be here all day talking about colic. But what an absolute pleasure it's been to sit down with these two brilliant veterinarians and surgeons and get an inside look at a disease that impacts so many of us via our horses. And I also want to encourage you all to visit platinumperformance.com/colic coverage. We didn't talk about this program here, but check out the Colic Coverage Program because it does really help, first and foremost, keep horses healthier via nutrition. But secondly, it brings a little bit of peace of mind into it because as horse owners, we do know that colic is ever present, and it is something that we worry about. So I'd encourage you to check that out at platinumperformance.com/colic coverage. And to Doctors Hassel and Gonzalez, thank you infinitely to each of you for being here and educating us on this topic. We appreciate it.
Thank you, Jesse. It's been a pleasure.
The opportunity.
And to all of you listening, thank you for learning alongside me, and I hope you'll join me on the next one. Until then, I'm Jessie Bengoa. Take care, all.